Hello, and welcome to the Opioids in Indian Country Learning Community Series. This is part one of our three-part series. My name is Mardella Sunshine Costanzo, and I am the Broad and Focused Technical Assistance Task Lead for the SAMSA Tribal TTA Center. On behalf of the Center's Contracting Officer Representative, Maureen Madison, and alternate contracting officer representative, Jan Dunbar Cooper, as well as our project co-directors, Lori King and Gloria Guillory, I'd like to thank you for joining us today. In a few moments, we will start our presentation in a good way. But first, I'd like to take a moment to review our process. Today's webinar is being recorded, and a replay will be available in the near future. Because we are recording, all phone lines will be muted to minimize outside noise. But please do not hesitate to use the chat box for questions throughout the session. Today's PowerPoint is available for download on the lower right side of the screen. Just left-click on the file and a download file button will appear at the bottom box. Clicking the button will start the download. Finally, we appreciate you completing the brief participant survey you will receive. This will help us better tailor our events to suit your needs. And now we will move over into our opening, and doing our opening for us today will be our Native Connections Grant Technical Assistant, Mr. Dave Braveheart.
Thank you, Mardella. This is Dave Braveheart, and good morning and good afternoon. This time I want to take this opportunity to honor our sacred breath in terms of the words that we share and convey to one another, and the words that we use to promote the healing and the messages in our communities, in helping our communities to heal and to live in a good way. So at this time, I'm going to honor this moment with a flute song. Oh, all my relatives, and I'll turn it back over to you, Mardella.
Thank you so much, Dave, for that beautiful opening. At this time, I would like to move forward with introducing our facilitators for today. Our facilitators will be the SAMSA Regional Administrator for Region 5, Captain Jeff Cody, and the Behavioral Health Consultant for Indian Health Services Bemidji Area Office, Mr. Chris Poole. They'll introduce us to today's guest as we move forward. I will turn it over to Captain Jeff Cody now.
Thank you, Mardella, and thank you, Dave. I'd like to welcome our participants today. My name is Jeff Cody. I am the Regional Administrator for the Substance Abuse and Mental Health Services Administration, SAMHSA, in Region 5, also the Bemidji area. I'm really honored today to help facilitate this conversation, this webinar, in partnership with the Indian Health Service. To recognize that our partnership is very important, working closer together, bring all the resources that we can to battle this epidemic. We know the impact of the opioid epidemic features many sectors, whether we are looking at the health sector, the justice sector, child welfare, housing, business. There's no untouched place in terms of the challenges the opioid have had in our tribal communities. We also recognize the impact across the lifespan, whether it's our infants who might be exposed to neonatal abstinence syndrome or our elders who might be in a position of having to take care of the infants in terms of the impact on the family. As Mardella mentioned, this is the first of a three-part webinar series. Today we are going to talk about specifically the Tribal Action Plan, how it can be a vehicle to help tribes bring together the community and develop a strategic approach to the opioid crisis. And then also we're going to hear about naloxone in terms of the critical role that it plays in terms of saving lives and helping to connect people to treatment. Future webinars will discuss the role of medication-assisted treatment, where we will hear from an integrated behavioral health clinic that focuses on pain management and addictions, as well as the role of medication-assisted treatment from a tribal healing court. Our last webinar will look at the role of recovery and recovery supports. We'll look at digital storytelling and the opportunities to engage with housing, health, helping to establish purpose, and then development of community for those people who are in recovery. But for today, I'd like to hand it over to Chris Poole, the Behavioral Health Consultant in the Bemidji area, who's going to talk about the data related to Native Americans in Minnesota. Chris?
Thank you, Jeff. As Jeff was saying, my name is Chris Poole. I'm a licensed clinical social worker by profession. I'm also the behavioral health consultant for the Bemidji area office, which serves a three-state region consisting of Minnesota, Wisconsin, and Michigan. We also have one urban program down in Chicago. We serve a total of 34 tribes across our region and 8 urban Indian programs. What I wanted to share with you today was just some information regarding opioid use and kind of what the statistics look like across our region, in particular in Minnesota. But before we get started with that, I wanted to talk a little bit about some of the terms that I'm going to be using, specifically opiates versus opioids. Opiates are drugs derived from opium, such as morphine, codeine, and heroin. Opioids is traditionally used to describe synthetic opiates, such as methadone, Percocet, Vicodin. Today, however, you hear the term opioid and opiates used interchangeably, especially among non-professionals or people not working within the drug treatment realm or within pharmacy and healthcare. But for the purposes of this particular presentation and the data that I'm going to be sharing with you, what I'd like to talk about is the contrast between heroin and all other opiates combined. So that's the setting that I'm going to be presenting from. And I'm going to be sharing some data from you from the Minnesota Drug and Alcohol Abuse Normative Evaluation System, also referred to as the DANE system. And the DANE system was really designed to provide policymakers, planners, program managers with data to drive current intervention, treatment, and prevention efforts. And again, this is really specific to Minnesota. This data is all out of Minnesota. As far as our region goes, Minnesota has the strongest data around the opioid use, around opioids. And one of the things I want to mention here is that the data we're going to be looking at is episodic, meaning that it has to do with treatment intervention. So the numbers are indicative of a person entering treatment. And there's a number of studies out there. The number of people using versus the number of people that are in treatment, that's a really hard number to nail down because people who are using don't just go on surveys and self-report. So as you might imagine, that it makes it very difficult to get a strong data set. However, Minnesota does have pretty good data set around episodic or treatment episodes. And when we start talking about data in Indian country, I want to be very concerned around sources of data, which in this case is going to be Minnesota. The slides that I'm going to be presenting from were actually put together by a man by the name of Rick Moldenhauer, which is the state planner for the state of Minnesota around substance abuse. When it comes to tribal data is another area where sometimes it can be very difficult to gather a real solid picture of some trends such as epidemiological trends, especially around substance abuse. Part of that is because tribal data has been abused over the years by non-tribal entities, such as states using tribal data and then competing with a tribe in grants and that sort of thing. So tribes, rightfully so, tend to hold their data close to heart, and it's part of tribal sovereignty, that whole government-to-government relationship. The first slide I'd like to talk about is what I was mentioning before. This is not the heroin slide. This is the all other opiates combined. And so it's your medications, anything that could be prescribed, really anything except for heroin. You're looking at two lines on here. Your first line is a blue line down here. And what that is all other episodic or episodes of care for individuals who are non-Native American. You notice it's pretty flat line. So it's all other ethnicities combined in essence. And here's what opiate admission rates looked like for Native Americans. And this is from 2000 to 2016. I want you to pay close attention to the date here of 2010, 11, 12. You notice things begin to flatten out. And then we begin to see a dip in those use, and we want to talk a little bit about where that comes from and why that's potentially happening. Now, this is the slide for heroin use in the state of Minnesota. Again, blue represents all other ethnicities combined. Purple represents Native American. One of the things that you'll notice is way over here in 2016, we're at 21 times the admission rates of all other ethnicities combined. That's a staggering number. I've heard a lot of information on data presented around opioid use in the United States, and I've heard some discussion on tribal opioid use, but this really paints a stark picture of what this looks like in tribal communities in Minnesota. Let's go on to the next slide here, and I'm going to put a side-by-side comparison here, and you'll notice that we've got the same years, and it looks like it might be a little difficult to see on this, and I apologize for that. But right around here is 2010. I see right around here, I didn't grab my counter. Right here is 2010, and you'll notice it begins to, there we go, it begins to flatten out here. You'll also notice 2010, we begin to see a spike. Well, there was something that occurred in Minnesota in 2010, and that was the implementation and the consistent use of the prescription drug abuse system, the PDMP, where physicians were required to report to and check PDMP for opioid prescriptions. So what we're seeing here is we're seeing users, people who are abusing prescribed opiates, begin to transition over to heroin. That's the speculation, at least, that's occurring. So we're beginning to see a drop-off in medication abuse because of the PDMP, but we're beginning to see a real significant uptick in the use of heroin. And to put this into perspective, one of the things that I wanted to share with you is, again, we had the blue line and the purple line. The blue line was all other ethnicities combined, and the purple line was Native Americans. Now, this little pie graph here demonstrates what the makeup of the state of Minnesota is from a total population standpoint. And this little red sliver right here is our American Indian population. So remember a couple slides back, let me go back there. I showed you at 2016, Native Americans were at 21 times the rate of all other ethnicities combined. We come back over here, and we're only 1% of the population of the state of Minnesota. I really think this paints a real significant picture around what opioids in Indian country looks like. And with that, I'd like to pass this back to Jeff and say thank you very much.
Thank you, Chris. I think the data is very, very important, as you indicated, and each one of those points on there reflects lives and impacts on our community. So I think the folks on this recognize that. So for our next presentation, unfortunately, Gloria Cobb was going to present on the Tribal Action Plan from Lac du Flambeau, but Gloria cannot be with us. However, Cipriano Mercurio from the Tribal Technical Assistance Center, who was heavily involved in the planning and the GONA that led to the development of the TAP over time, is here to present on the Tribal Action Plan, how it can be a vehicle to help bring the community together, engage the stakeholders, and develop a strategic plan. Cipriano?
Yes, thank you, Captain Jeff Cody, and thank you, Chris Poole with Indian Health Services, for the opportunity to contribute to this very important work. As a training and technical assistance center and the opportunity to support Indian country through prevention and behavioral health wellness, we have the opportunity of connecting and building and learning all kinds of different relationships from across the spectrum of prevention, treatment, and support and promotion with Indian country across 34 states, 572 federally recognized tribes, the state-recognized tribes, the urban Indian health centers. And through our efforts in supporting SAMHSA's training and technical assistance, we get reach-outs from tribes regarding all kinds of different challenges. And the opioid epidemic has really brought a lot of insight to our team and a lot of opportunity for us to learn. And so when we get inquiries from the Training and Technical Assistance Center, like we had with Lac du Flambeau, and again, I could share from my angle as a Training and Technical Assistance Coordinator, it's really how do we understand where to start? Where do we begin working with the tribal nation? How do we build relationships in the virtual world, leverage resources for collaboration, share information, make sure that we're speaking the same language, and then really promote engaging on-site training and technical assistance. And with the Lac du Flambeau Tribal Nation support, we were able to connect with Gloria Cobb's team, with her social services department, her family services department, her prevention team, the public safety team, the housing team, and they were really talking about what do we do to address the challenges of opiates, and other substance abuse-related factors that come with it, because we know the epidemic that is happening is very systemic. And what we've learned is no one agency, no one department, no one program is going to help our tribal citizens overcome the systemic challenges of substance abuse, substance misuse, or even the levels of addiction that range across opioid and opiate epidemics. So when we had the opportunity to build a relationship with Lac du Flambeau, one of the places was where to begin, where to start. And again, every tribal nation we know has their own tribal protocols and processes that they mobilize their community, whether it's our elders councils, whether it's our clan groups, whether it's our community advisory boards. We have these processes, and we have dedicated community champions who are looking for ways to support. So one of the things we did was reach out to Lac du Flambeau, the point of contact team, and said, we need to engage the whole community. We need to engage your leadership. We need to start making sure that we're speaking the same language, because when we talk about laws and policies and training and technical assistance, the way the federal government is set up is it's very siloed in nature. And so how do we start to connect all of the professional experiences that are supporting prevention services in the trenches on the local level to see, are there duplicative processes?
Can we work smarter, not harder? How efficient is the program running right now? And how does a tribe know if they're successful in the implementation of goals and objectives towards their stated priorities? And in this work, we're always looking for ways to engage. And one of the most helpful philosophies that braids Western thought process with opportunities for tribal nations to look at their tribal protocols is the system of care philosophy. And this model that Lac du Flambeau has here on this slide is really a reflection of the development of a system of care. How the different housing, the health and wellness, the domestic violence programs, the diabetes programs, the nutrition programs, the tribal leaders programs come together to develop an effective community-based support system for their tribal citizens. The core values of the system of care philosophy are very unique. It's family-driven, it's youth-guided, it's built on the strengths of the community. It's based in the locus of services and support that are supporting the citizens in the local area. So we use this philosophy to bring the community together, and we also really looked at what is Lac du Flambeau's community readiness. Now, everybody on the call, if you're not familiar with the community readiness model, it is an awesome model that really gauges a starting point for the opportunities to implement health wellness promotion. When you think about it, historically, tribal nations have received substance abuse treatment grants or prevention grants, and the number one thing we do in Indian country is really hire a substance abuse counselor. But if the community is in denial about the challenges that are impacting the tribal citizens, then that substance abuse counselor's office is going to sit empty for 50 weeks out of the year. And so, is that an effective use of resources? So by gauging a level of readiness, tribes are starting to use this model to identify most effective strategies to meet the level of readiness to enhance the prevention services being offered to their respective tribal citizens. So if anybody's unfamiliar with the community readiness model, it's a low-tech, low-cost model developed by Indian people for Indian people. And with this model, tribes are developing workforce within the community to do some collaboration evaluation and identify a starting point for the implementation of prevention services. The second thing we really looked at is how do we pull a whole community together to engage in conversations across professional silos. And just like on the local level with housing, law enforcement, prevention, and treatment, every department has its own culture. In the federal government, every administration has its own culture. And so how do we loop these prevention opportunities across the system towards coordinated and collaborative goals and objectives? The one model that seems to be the most effective for us is the Gathering of Native Americans GONA curriculum. This curriculum, developed in the early 90s, which primarily focused on healing from historical traumas, has been an awesome tool for us to consider once a community starts the healing process and identifies next steps. How do we move forward having strategic, collaborative, solution-focused conversations within our tribal nations to develop prevention priorities? And the GONA framework has been an awesome tool that allows us to bring together multiple professional experiences, community members across the age spectrum, families, tribal leadership, and our non-native allies together to have collective conversations. And the 3-year process of mobilizing the community, making sure everybody's on the same page, information dissemination about the Tribal Law and Order Act, Tribal Action Plan, working with tribal leadership to get the direction from the council to help the social services move forward, and then work with the social services department to bring everybody up to speed, and then develop a starting point for services with the support of a framework to have systemic conversations. We created, I shouldn't say we, the Lac du Flambeau Nation took the initiative and created a strategic plan that is unifying their social services, their family services, their public safety services, their prevention, treatment, and school system services under goals and objectives under one plan. And now they're using that one plan to develop resources across the community in all of these different prevention areas. It's truly an amazing work. I can't say it as beautiful as any Lac du Flambeau tribal member who participated in the effort would, but I'm thankful to share this information. And I will outline some of the training and technical services support use, and also talk about how tribes should consider training and technical assistance under the opportunity of the Tribal Law and Order Act. Jeff, at this time, I would like to pass it back to you. And BC, if any questions do come up around the Lac du Flambeau initiative, I'll be prepared to answer the questions. Thank you very much.
Thank you, Cipriano. I think you nicely articulated how the TAP, given the multitude of partners, and as we talked about the impact, how that certainly could be a mechanism by which we can advance the strategies that help address the opioid crisis. And I'm sure there's some of the, I think we have over 300 participants who might have engaged in that TAP. So if folks in the chat box want to give their own comments in terms of the worth and value, that might be something that we can see in our chat box. Right now, I would like to introduce at least one of our next presenters, Captain Cindy Gunderson, who is the acting Chief of Operations at the Red Lake Hospital. Her and her team are going to talk about their first responder naloxone program. So thank you very much, Captain, and the floor is yours.
Thank you, Jeff, for that introduction. We're honored to be with you here today, sharing the Red Lake story surrounding opioid crisis response services. As Captain Cody said, my name is Cindy Gunderson, and I am a pharmacist at the Red Lake Hospital. We'll focus today on our community collaborative and our naloxone overdose reversal program for first responders. With me today, I have Captain Dana Lyons, who is the Captain of Police for the Red Lake Police Department, as well as Lieutenant Samantha Gustafson, who is a pharmacist at the Red Lake Hospital. So we heard Dr. Poole give us a little reflection on the data in Minnesota. And I just would like to share a little additional information beyond what was already shared about our overdose rates here in the state of Minnesota. As was reflected in the 2013 Minnesota data, our American Indian population is 5 times greater opioid overdose mortality risk based comparatively with our white counterparts. The Red Lake Nation was very keen on this data and had noted similar patterns of opioid overdose mortality in our area. Captain Lyons is going to tell us a little bit more about the Red Lake Reservation as well as introduce the initiative for us.
Good afternoon, everybody. I'm Captain Lyons from the Red Lake Police Department. I'm a Red Lake Tribal Band member, 17 years in law enforcement serving the Red Lake Nation. Red Lake is a closed reservation in northern Minnesota, all land held in common by tribal members. We have our own laws, we have our own government. Our enrollment is 11,400 members. Our law enforcement is tribal only. We have 34 sworn police officers to staff and facilitate 24-hour dispatching and law enforcement response. We cover 840,000 acres of federal Indian trust land, or equal to 1,259 square miles. The Red Lake Band of Chippewa Indians declared a state of emergency due to the opiate overdoses that occurred here in Red Lake. I'd also like to mention that in 2017, the department spent a tremendous amount of time and resources fighting the war on drugs, and there was one drug-related fatality due to opiates in 2017. Legal drugs consisted of heroin, methamphetamine, prescription pills, and marijuana. There could have been a lot more lives lost, but law enforcement, EMTs, saved many lives due to Narcan. If it weren't for the support from our tribal council and the collaboration with the IHS pharmacy staff, we wouldn't have received the training in Narcan, but we did receive the training, and it saved many lives.
Thank you, Captain Lyons, for that overview. So where did we begin? A little bit about our community collaborative that Captain Lyons mentioned. We noticed that uptick in opioid utilization, overdoses, and babies born dependent on opioids, as well as an increase in our Family Children's Service referrals and out-of-home placements. As a result of this, the tribe created a community collaborative that we called Helping Hands in January of 2015. The group started to focus on the neonatal opioid withdrawal syndrome numbers. We meet monthly with a plan to address programming to impact these neonatal opioid withdrawal response rates. We've also discussed best and promising practices and novel approaches to impacting the opioid crisis more broadly, including our naloxone initiative, was really born out of this community collaborative. As you can see from the slide, our members include representation from all Red Lake programs, including chemical health, the hospital, the Department of Public Safety, Family Children Services, the courts, our shelters, schools, public health, nursing, all down the list of our care providers practicing within the reservation. So we always say a picture is worth 1,000 words, right? So I just wanted to share some images with you. As we said, this is a partnership between the Red Lake Police Department as well as the Red Lake Hospital. You can see our logos on the screen there. In the upper left of your screen is the Director of Public Safety, Bill Brunel, demonstrating our FZO naloxone device. To the right is our marketing tagline, that naloxone, together we can give it tomorrow. And in the center is a picture that we use to mark our naloxone locations where we store the naloxone, so any of our trained first responders are able to know where they can find naloxone to quickly respond to an opioid overdose. So how did we get there? We started our naloxone initiative by training and equipping our Red Lake Emergency Medical Services to carry naloxone in the nasal formulation in August of 2014. From there, our initiative grew. We decided to start doing a broader first responder training program. And we quickly realized that we needed to create a good faith immunity code within the tribal code. This relieved the civil and criminal liability for first responders for not only our health provider staff, but also for our EMS services as well as the police department. Next, we applied for the HRSA Rural Opioid Overdose Reversal Program. We were in a grant application. We received that award and did a 1-year no-cost extension. Through that, we partnered with between the Red Lake Hospital Pharmacy and the police department to begin that collaboration in December of 2015. So what this looked like was again, it was a small grant that created a training program as well as helped to assist with the initial naloxone distribution to our first responders. And why the police department? As Captain Lyons said, we have a large reservation. Our law enforcement officers are generally first on the scene. So we were finding that our EMS staff weren't the first on the scene. So the police and fire department were our first responders. So we felt it necessary to train and equip them to respond. The picture on the screen there is our first training collaborative from that December 2015 session. And we were pleased with our first save on March the 3rd of 2016. So Lieutenant Samantha Gustafson will hear a little bit about our training initiatives as well as the elements of our program.
Thank you, Captain Gunderson. All right, so when we started the naloxone training program, it was developed with the understanding that opioid overdose reversal is just one piece to the puzzle in regards to the epidemic as a whole. In order to successfully treat opioid use disorder, patients often need access to medication-assisted treatment and behavioral health programs. Providing and educating on naloxone was just one tool used to save lives and give those in need a chance for tomorrow, or a chance for them to obtain the chance they need for recovery. With this in mind, the Red Lake Naloxone Training Program was created to provide education on symptoms of opioid overdose, naloxone effects and administration, aftercare, and first responder precautions. Recent programs have also been updated to include emerging trends in synthetic products in an effort to keep the community informed. Participants also learn about the importance of activating the emergency response system, understanding that their supply of naloxone may not be enough to achieve and sustain overdose reversal. And with that, Captain Gunderson will go through our training video that was developed.
As I mentioned, we had a small HRSA ROAR grant, and we had some additional funds that we decided to expend filming a comprehensive naloxone response video. So this video includes the signs and symptoms of opioid overdose, the risk factors for overdose, as well as the necessary steps to respond to an overdose. We cover the three available naloxone formulations, as well as aftercare instructions. So we've included this YouTube link for you to access this video if needed to support and augment your training videos in your local communities. Additionally, with the grant, we were able to host a program. This is very near and dear to Captain Lyon's heart, so I'm going to kick it back to him to tell us a little bit about this community event.
Okay. We decided to have a big training on opiate overdose prevention and treatment. We called it the Take Back Our Community, which I thought it was pretty awesome. Basically what we did was we provided a PowerPoint presentation on several topics such as naloxone, drug identification, and other topics. We actually went around the group and presented illegal drugs in sealed containers so that people could see what drugs actually look like. We also had them paraphernalia present so that they can see if that's anything inside their homes. After the presentation was done, a lot of the members came up with a lot of questions and said they've seen some of this stuff in their homes already, and they didn't know what it was. So now after that presentation, we received kind of a lot of reports of drug activities in different homes. Many community members and elders have never seen it, so they didn't recognize paraphernalia. It may have been present in their homes, and now they're equipped to identify and report legal drug activity. But we reached out to them, and it was a great training, and we also followed up with that with community policing activities. Law enforcement staff partnered up with IHS pharmacy staff to hold Narcon trainings for the community members to share opiate abuse information and inform them what resources are available for their loved ones and how they can save lives with the proper training. I will give you a little success story. We did have an overdose occur at a residence, and the people who were at the training actually received the Narcan, and they administered it to this person and actually saved his life. If it wasn't for them, this person probably wouldn't be alive to this day. So, and when asked how they did that, they said they learned it from our training that we hosted, and that was really a good success story. It means that the community's out there helping people. Now law enforcement doesn't have to stress as much as responding to calls like that if the community is already equipped to handle some of it. I'll turn it back over to Cindy.
Thank you for sharing that story. It was an amazing event that really, truly helped us to pave the path forward. And as Captain Lyon said, we had over 250 community participants, and we were able to train 90 community responders. We also covered topics such as sexually transmitted infections, as well as caring for substance-exposed infants. So I think we had 3 breakout sessions running concurrently with this initial one-day event. So back to Samantha, we'll talk a little bit about our next steps in responding to the opioid crisis in Red Lake.
All right, so really as the definition of first responders was expanded within the community, we began to seek interest from local programs in an effort to further expand access to naloxone. Our training program was promoted through flyers, social media, email messaging, and it all focused on community programs, but those especially that were represented at the mobilization event that we just discussed. This sparked a lot of interest from a wide variety of groups, from the tribal council to schools, casinos, and health station staff. People quickly learned that administering naloxone was not only for trained medical professionals, but rather that anyone could do it. Everyone willing to learn had the potential to save a life. The Red Lake community embraced this concept, resulting in the training of 462 first responders with 215 devices dispensed. A total of 87 kits have also been distributed to at-risk patients and proxies, with countless doses used by frontline first responders. These men and women are truly the reason that lives are saved. So on the next slide you can see here, we kind of made a little infographic regarding our data from 2017. And so you can see multiple calls that were made by EMS, police, fire department, and community staff members, which resulted in 301 doses of naloxone given in 2017. With a total of 56 opioid overdoses reported, we noted a 330% increase from 2015, equating to about 1 opioid overdose every 6 days. One could assume that this number may be even higher, as some people do not seek medical treatment due to the negative stigma associated with opioid use disorder or fear of legal repercussions. Unfortunately, there's no way for us to truly determine what impact that might have. The year 2017 also showed trends in a higher average dose per encounter, increasing to 8.56 milligrams from 3.07 in 2015. We can only speculate that this might be due to pure product or larger volumes consumed, but it certainly solidified the need for expanded access to naloxone. First responders from across the community have also made every second count through prompt administration of this reversal agent, with only 1 death noted in 2017. And with that, I will pass it back to Captain Gunderson.
So as you can see, early access to naloxone truly saves lives. Naloxone distribution programs are a good first step in a comprehensive community response. So where do you start? As we know, tribal communities have very rich resources within the community. Look at your community. Know what resources you have available. Who are your stakeholders? One thing with Red Lake we noticed was really including our elders in this response. One of my favorite moments from the naloxone training programs was at our Red V event, where I got to work with 2 grandmas on how to administer naloxone. So don't forget about the elders. What resources do you have available? Do you have an IHS program within your facility that can assist you with procuring naloxone, with training your community and first responder staff? They can also support with data collection as needed. Indian Health Service has a variety of resources available as well. We've listed a link there for you that includes some example MOUs that you can use within your tribal communities to form partnerships with the IHS programs, again, to help with training and naloxone procurement. There's forms in there. There's a first responder train the trainer toolkit. There's links to the two training videos. There's a law enforcement testimonial in there as well, if you need help on selling the actual naloxone program to your first responder staff. And then finally, you can consider co-prescribing naloxone for at-risk patients within your medical facilities. So patients that are known to have substance use disorder, as well as patients that have chronic opioid prescriptions at high morphine daily equivalent, may benefit from having naloxone for home administration. So thank you for the opportunity to share the Red Lake story today. I will turn it back to Jeff to introduce our next speaker.
Thank you, Cindy. It's a great story in terms of the mobilization, and that one slide that you guys had up in terms of looking both at, from the EMS where you started, and then kind of moved on to other first responders in terms of the police and other folks, that ultimately really the community is I think really impactful, and the results are obviously there in terms of lives saved. So thank you for sharing the partnerships and the story. I'm going to hand it back over to Cipriano, because I think we're having a couple questions in terms of, as we talked about the TAP and naloxone as well, how do we move forward? What are those resources out there? So Cipriano, if you want to talk about what resources might be available to help move forward.
Thank you very much. At this time, I would definitely like to send a shout out to my partner in crime in doing a lot of the Tribal Law and Order Act Tribal Action Plan efforts, Ms. Sarah Pearson. She developed this TAP Prezi, and if anybody's unfamiliar with Prezi as a tool, Prezi can combine multiple PowerPoints under one link. And so this Prezi, and there is a link to the web address on this webinar, combines multiple learning experiences around the Tribal Law and Order Act and considerations and support and information for tribes around tribal action plans. And so as you open this page, if you do take a look after this webinar, you will see these two arrows here that will help you navigate the Prezi process. And we're going to start right here in the origin section, or in the background information of the Prezi, that really gives us some background on the Tribal Law and Order Act. And most importantly, the TAPs that I'm going to be referred to, or the tribal action plans, are nothing new. These have been asked before by federal agencies in previous decades to really look at is there a strategic plan that is guiding all of tribal nation support and services that can contribute to directions for training and technical assistance? How can the feds support on tribal-led goals and objectives? This law, the Tribal Law and Order Act, was signed into law in 2010, and it really mandated agency leaderships to enter an MOA. And in that MOA, it really was built upon the Indian Alcohol and Substance Abuse Prevention Treatment efforts, and it really looked at how the Department of Health and Human Services, the Department of Justice, and the Department of Interior, which all have prevention support efforts for and with Indian country around substance abuse prevention and public safety, can be linked, can be collaborative, and how these federal agencies can be networked together to think about how their specific efforts can be coordinated and implemented in an effective fashion within the local communities or within our specific tribal nations. This law really was built upon the Snyder Act, Indian Self-Determination and the Education Act, and the Indian Alcohol and Substance Abuse Act, and that was all amended by TLOA. And basically it organized these three departments. And these three departments, again, are linked. They come together on monthly basis. They've been working together for years and really thinking about how do they collaborate. Some of the biggest challenges have been that each of these federal administrations have their own culture, their own languages, their own processes. Their calendars aren't matched up. They use acronyms that could have the same letters of the English language, but yet mean something totally different. For instance, if I said TAP under the Department of Justice, people that work within the DOJ realm would think of the Tribal Access Program, which is the National Criminalization Data portal that provides information to Indian country on crime data statistics. But if you say TAP in SAMSA, it means the Tribal Action Plan, which really coordinates 9 federal agencies' training and technical assistance efforts to a tribe. And so the acronyms and getting familiar with this culture, getting familiar, has been no small feat for our TA team, but we do as much upstream learning as we can to support any downstream efforts we get a chance to support. In the TLOA efforts and in the MOA, the federal agencies are geared towards doing 3 things in the MOA, and this goes across Health and Human Services, Department of Interior, and Department of Justice. They are charged with determining the scope of alcohol and substance abuse problems faced by tribes. They are charged with identifying the resources and programs of each agency that would be relevant to coordinate efforts, and they are charged to coordinate existing agency programs with those established under the Tribal Law and Order Act. So this is really the meat and potatoes of the law. This is the responsibilities of the federal agencies to contribute, and their request for tribes is really to develop a tribal action plan to gear the training and technical services that would be most relevant, most helpful, led by tribal nation support. If anybody wants to see the MOA, we have copies of it we could share specifically with tribes and tribal leaders on the call or with tribal organizations, as well as you could see the MOA on the register, and it is available. But the TAP is the key in the MOA policy for tribes to stay in the driver's seat. And Sarah, I'm going to use your line right here, and I love your image. But, you know, how do tribes stay in the driver's seat on the identified goals and objectives? As a TA center, we get invited to learn a lot from the federal process. I've lived in Washington, D.C. for 6 years, working in D.C. for 7 years, and I'm still learning new things about federal government, federal agencies, and efforts that support Indian country. But how do tribes stay in the driver's seat, especially when we have these systemic challenges or even the state of emergency process around opioid and opiate epidemics? And so one way is that tribes can develop an overall strategic plan and really outline what kind of training and technical assistance, what kind of services would be most helpful, and what kind of coordinated steps would be most helpful in tribes looking at and supporting successful prevention, treatment, and safety efforts. So I'm going to back out of this Prezi now And out of those federal agencies, the SAMSA Office of Indian Alcohol and Substance Abuse is charged with overseeing their federal partners. And on this page, if anybody Googled SAMHSA, SAMHSA.gov, TLOA, you would have this main page join up. And these are the overview of the federal partners that are currently working with SAMHSA on this initiative. And this is their main web page that they get resources out on the Tribal Law and Order Act. Here is a box that is really focused on the resources to develop a TAP, these two boxes right here. They put out a quarterly newsletter, webinars, and other events just like this to share what they're doing to support the implementation of TLOA and to disseminate resources and information. And most of all, you know, and unfortunately, we haven't seen any specific funds dedicated to TAPs. We have seen an array of training and technical assistance that is being offered to tribes to identify challenges, barriers, or opportunities to support prevention efforts around training and technical assistance. And this is, again, their main webpage going out. The second main office that will be most helpful for tribes who are considering developing a tribal action plan is referred to as the OTAP Office, or the Office of Tribal Affairs and Policy. This is one of the highest level of offices within SAMHSA. The OASA staff is embedded within the OTAP office, and this is one way tribes have the opportunity of requesting support from SAMHSA and really enhancing tribal transparency to really unify some of the federal partners and support collaborative training and technical assistance at the same time. For instance, and I know one of my colleagues is on the call here from the Fox Valley Technical College, which provides a lot of training and technical assistance with DOJ, Ms. Justine Soto. We had the opportunity of actually supporting tribes who are developing a tribal action plan with DOJ and SAMHSA, really supporting the training and technical assistance, engaging the tribe on multiple occasions and on multiple levels to have coordinated discussions about justice and SAMHSA's prevention efforts at the same time. And so how do we link training and technical assistance so we could have systemic conversations at the same time? So OTAP Office was instrumental in creating that transparency and supporting the collective training and technical assistance efforts identified by the tribe. For anybody who is really targeted towards the Department of Justice funding, this is the main webpage that the DOJ uses for their Tribal Law and Order Act. And as you can see, they do a synopsis of the law here, and then they have a lot of resources targeted towards developing the infrastructure for public safety and the efforts of court and public safety within tribal nations. The Tribal Law and Order Act, they have a lot of pages here, and as you can see, here's the Tribal Access Program. So if you are receiving DOJ funds, then the Tribal Access Program could be confusing. So again, just be cautious about your acronyms. But down here, I just want to say, with the training and technical assistance, here is the way the Department of Justice is unrolling their training and technical assistance. And here you can see the topics and eligibility. Here's the TTA providers, and here's their grants and financial training. Again, they are a vital partner in the support and the development of public safety, prevention, and wellness for our tribal citizens. And the Department of Justice does a lot in bringing resources to Indian country. But I know that a lot of our tribal prevention programs are stretched thin already, and to gain these new ideas or find where these web pages and resources are located within the overall system is no small feat. So they're starting to organize a lot of their training and technical assistance within one area for tribal nations to identify opportunities for support. And here you can see the list of training and technical assistance providers. Again, one challenge is, just like the federal government programs, these training and technical assistance centers also have kind of siloed statement of works. So for us at the Tribal Training and Technical Assistance Center, just to give you an example, if we receive a training and technical assistance request on treatment, which we are a prevention center, we have to reach out to another TA center and request their support, build a relationship, or refer the tribe over to that other TA center. And a lot of the programs are like that. There's very few integrated centers that could help with everything, but it really pushes our staff, our team, to build relationships with, just like Justine Soto or my colleague Sarah Pearson, to build working relationships so when we have systemic challenges come across our desk, how are we relying on other programs and other experts to build more resources and more effective trainings for Indian country. Another partner under the Tribal Law and Order Act, and this is the Bureau of Justice Assistance under DOJ, the Office of Justice Programs. Here is how they are getting their information out on the Tribal Law and Order Act. For anybody on this today's webinar, this is where a lot of their information for BJA grants come out. As you could see, they're pumping out a lot of resources and links, and they also have their training and technical assistance tabs here. So BJA has a service provider for 2013-2014. They're developing webinars. I know sometimes with these federal websites, their information is out of date, but their links might be still vital. So here you have the Tribal Law and Order Resource Center, and it will bounce you out of here. And for this presentation, I'm not going to follow that link, but that's where a link where you'll get their Taloa Resource Center in regards to the BJA identified training and technical assistance efforts. One great thing that came out earlier this year that was a SAMHSA-led effort, and if anybody's unfamiliar with this page, it's called knowledge.samhsa.gov, and they brought together all of their training and technical assistance centers under one website. Before, you had to kind of scurry around, find out, have email listservs, and all this information out. And at the beginning of this fiscal year, they really start to kind of unify the opportunity of training and technical assistance over the SAMHSA system as well as some of their federal partners. And as you can see on the right side of your screen, these blue links, you can link on directly to those TA centers. Now, not all TA centers provide training and technical assistance. You have to, on site, you have to kind of look at exactly what their focus or their expertise is and how to get connected. Another big challenge is they all have their own different ways to get connected and their target areas. So we're still learning more on how to synthesize the information for Indian country, but at least now they're housed under one website where we can at least find them and start clicking and making connections and hopefully connecting the dots for more collaborative, coordinated training and technical assistance efforts that are matched at the level of readiness the tribe identifies under tribal-led goals and objectives. And as you can see here, these pages, it goes on to page 2 and 3, and our center is linked here. DTAC, which does emergency response strategic planning around behavioral health issues. FASD, which is really primarily focused on outreach and information dissemination right now. Indian Health Services linked here. So this is a great web page. We hope it gets used because we know in the federal government if we don't use it, we lose it. So we hope that this Knowledge Center website becomes kind of a focal point for tribes to really consider what kind of training and technical assistance efforts are going to be most helpful around our efforts. And last but not least, here is the Tribal Epidemiology Centers within Indian Health Services, really effective partners for any tribe considering developing a strategic plan. These are regional epicenters, not, as our work over the last few years reaching out to Indian country and identifying who are the collaborative partners supporting tribes. It never ceases to amaze me on the strength of Indian country or also the opportunities or challenges of Indian country, and data is one of them. And so how do we build working relationships with our regional epicenters? What kind of information can we harvest from them? What kind of information, what kind of data can we harvest from the federal government? And how can we complement that data with possibly our own research and evaluation methods? This is another discussion that's going on under the Tribal Law and Order Act for tribes who are really looking at strengthening their capacity and infrastructure for collecting their own data, protecting their own tribal citizen story, and using their own data to develop prevention priorities or prevention resources through their funding opportunities. And so don't discount the 12 techs. They could be vital pieces for future collaboration efforts or strengthening current collaboration efforts. So with that, I just want to say thank you very much for your time here with that, and I am going to turn it back to Mark, and I apologize, Mark, for closing out my screen so fast again. But thank you, Captain Jeff Cody and Indian Health Service, and most of all, thank you, Red Lake Nation, for your support with the tribal citizens in your area and your support with Indian country as a whole. I know that was a lot of information, Jeff.
Thank you, Cipriano. Appreciate you drilling down. And I know I'm starting to see a lot of different questions in the chat box, and I know that BC is sort of collecting these questions, and we hope to answer some of them now. One I want to answer just sort of real quick. I know that we had mentioned that this is the first of 3 webinars, and in terms of our next webinar, we're specifically focused on treatment. I mean, I think as we sort of looked in terms of the planning committee sort of looked at, how to begin to sort of mobilize the community, and then in terms of that crisis response, but ultimately, we want to get people into treatment, then into recovery. And with each of the different webinars, as Cipriano kind of laid out, we want to sort of make available what is the technical assistance, whether it is coming from SAMHSA, whether it might be coming from Department of Justice, or Indian Health Service. What are those different vehicles that folks might reach out to, and who are those appropriate points of contact? BC, in terms of how you want to go about the Q&A, I'm going to sort of defer to you in terms of how we should kind of go about that.
Great, I appreciate that. Thank you, Jeff. And then we will also know that in addition to Jeff and Chris, we hope our team that's on the line will help answer these. So let me just start with a comment that was made right at the top of our discussion when we were discussing GONA, and that was Bernita with Havasupai noted that she feels we do really need to make a strong effort in Indian country to come together, and she really appreciates hearing how tribes are doing this, and I think we all do. This is an important issue for all of us, and it's good that we are all here seeing how we can help our people. Lawrence French then asked if IHS collects substance use disorder data across Indian country, and Chris and Jeff, I'll let you guys address that.
This is Chris. Unfortunately, the answer is not going to be straightforward. Within IHS, you have 3 different segments of treatment. You have basically what we call the ITU, or you have IHS, which is the federal side of the house, T is tribal, and U is our urbans. IHS as a whole, all your federal programs are all on a federal system, which is RPMS. That's our electronic health record. And there is substance abuse data collected within that with regards to our federal service units. Most of our substance abuse programs, though, are tribal programs across the country, and they are not necessarily in RPMS, and so they may be collecting their own data, but that doesn't get shared with IHS, I want to say consistently, because tribes have the discretion to share or not share. That's all part of the, data sovereignty and tribal sovereignty. And then we have the urban programs, and some of our urban programs do collect some of that data and do share, and others don't. It kind of depends on what their contract is, what kind of facility they are, whether they're a substance abuse facility, whether they're just information referral. And then our tribal programs, under Public Law 93-638, that allowed tribes to take over their own health care. So a lot of tribes have taken over and began to, it's either called self-determination or self-governance, run their own health care systems. And those tribal programs, again, when it comes to data and tribal sovereignty, they can share with IHS if they choose to, but they're not required to share with IHS. So in a nutshell, yes, there is some substance abuse data. Is it homogeneic? Is it a robust data set? Not necessarily, because there's issues around tribal data. There's issues around which EHR they're on. If they're a tribal program, they can be on the IHS RPMS web EHR, but they don't have to be. They can go with a private solution. So there's a lot of ifs, ands, or buts with regards to IHS's data set around substance abuse. I know that's a little convoluted, and it's a short explanation to a really robust discussion. Jeff, did you have anything you wanted to add?
Yeah, thanks, Chris. And then in terms of the SAMSA, and SAMSA has one of our 4 centers. One is the Center for Behavioral Health Statistics and Quality, and they administer sort of national surveys as well as, and from that we can determine in terms of pull out some of the tribal data from the national surveys and maybe some of the state data, but maybe perhaps not to the level of detail that the person who is asking the question is seeking. But I would certainly go to, and we could put up that link to the website in terms of where you could find some of our reports and begin to kind of look at some of that data might be useful for your purposes.
Okay, great. Thank you, Jeff and Chris. And I did see a comment out here from Aaron Wakini. Again, apologies if I mispronounced that. He notes that almost every state has a student drug survey which collects race data. We use that in Oklahoma, but have heard of no other tribes or tribal organizations using this excellent youth data. Maybe they just don't know the data is out there. So maybe something to keep in mind that can be used in your state. Our next question was from Crystal Roach. I'm new to the community. Where can I learn more about Indian country drug endangered children training? And I'll leave that open to any of us.
Hi, this is Jeff, and I'll give it a start to kick this off. Drug endangered children, also known as DEC, as some folks refer to it as, it's a national organization, and from my understanding that different sort of tribes and states would sort of implement the programmatic aspects of it. There is a website that would contain additional information in terms of there's points of contact that you could reach out to. From my understanding, I know we've had presentations, I think, from Chris, you might know better in terms of some of the Wisconsin tribes that have been engaged in this, but I don't know if other folks in the chat line have more information or further involved. My knowledge base is very on the surface in terms of the DEC specifically.
There's actually a website called wisconsindec.org that has a lot of information on there, and the University of Wisconsin has been pretty engaged in drug endangered children. In fact, that's the group that came up to our conference last year, Jeff, and I'm blanking on the young lady's name. I'm going to search my inbox, and I'm going to put myself back on mute.
Okay, great. And I see it looks as though we've gotten some in the chat box. Folks have entered some resources as well, so we appreciate you all sharing your information. We'll move on to the next question. Melanie Smith asks, I want to do a GONA here with the community strong drug endangered children's efforts. How do I do this? And maybe we'll ask Cipriano.
Oh, yes. Well, thank you very much for the question. One of the things I know that would be a very first place to start is that majority of federally funded programs have some kind of training and technical assistance provider connected to them. So one thing I would ask for is I would reach, obviously identify the core and create some transparency and talk about the goal and saying you want to go to a wellness event. And as we know in Indian country, once we verbally say something, that gives it energy, and then how do we move on it? So one is I would really state it to it and see who the training technical assistance providers are tied to the funding stream. Now, there are some funding streams that might have TA providers that can't support or do not know or unfamiliar, which we see a lot because in Washington, D.C., there's a lot of organizations providing support to the federal government that might not have rich knowledge or strong understanding of work in Indian country. So one is I would definitely look at who the TA provider is connected to any funding stream. Second is there are TA centers that provide support to Indian country that you don't have to be a grantee of that organization to receive training and technical assistance from. One of those is our center, the SAMSA Tribal Training and Technical Assistance Center. In this center, you do not have to be a SAMHSA grantee to obtain training and technical service support. If you go to our website, we actually try to make it as easy as possible to connect to tribes in thinking about training and technical assistance efforts. You just Google Tribal TTA Center. It will be the first link that pops up. On our main home web page, on the right side corner, you'll see a red box that says Contact Us. All we ask for is your name, your email, and a description of what you are considering. That kickstarts our process of connecting with you, setting up a conference call, and learning more about your TA request. Through our process, we organize your request in the SAMHSA, what they call a tracker. We submit that tracker, and when we receive approval for that tracker, we get the opportunity to leverage resources with you and for you. Now, we can't pay for everything, but there's a lot of things that we're collaborative with, but we also know a lot of things around training and technical assistance needs to be led by the local community, thinking about all our cultural protocols, how to integrate and outreach to the community, where are we going to have the training. So any training and technical assistance center has to be thoughtful about those processes, have to be considerate about what their limitations are, but also what are the needs of the local community to really have an effective training. So if a TA center is unfamiliar with that, we hope that they reach out to us as a TA center and ask for support from us to help them with any particular training. But if you submit your TA request directly to us, we would have the opportunity of connecting, building relationship, and learning ways that we could consider support. Now, there might be a lot of TA requests that a tribe will submit to us, and if it is out of our scope of work, we will still connect. But we should be really thoughtful as a team to think about what resources we're going to bring to the table if we can't support that effort. So it really gives us a lot of homework in that. So the GONA is the #1 requested TA effort, and our team has been trying to be real thoughtful about how we do it. We do GONAs, but once a community has a lot of experience of GONA wellness events, we really look to train people in the region, the area, or even within the tribe with the training of facilitators. Our hope would be that in the next few years, those trainees who got the training would be facilitating GONA events on behalf of their local community, really thinking about workforce development, enhancing capacity for tribes to do their own GONA. And when we have facilitators based in the local community, that really provides an opportunity for the local lens to shine. I hope that's helpful, BC. Thank you.
That is, Cipriano, thank you very much. John Shooter says, or notes, naloxone may save a life. How is that individual then connected to treatment resources? Are treatment resources available? And I would like to pass that on to the Red Lake team. Thank you.
Thank you for that question, John. At Red Lake, we did immediately note that we needed to improve our naloxone overdose rescue aftercare services. So it really involved, one, training our ER provider staff, both providers and nursing, on trauma-informed care, as well as stigma and addressing post-overdose resuscitation. After the event, it's sometimes not, it's a good time to refer to care, but oftentimes the assessment is not able to be done during that ER visit, just either one based upon the availability of the assessors at Red Lake or the hours of the day to immediately do an assessment, as well as the ACM placement criteria maybe not being overly reliable in that post-overdose resuscitation space. So for Red Lake, we administer the naloxone take-home dose, as well as initiate a fax referral to our chemical health program that includes the patient's follow-up phone number so that chemical health can follow up within 24 to 48 hours for that assessment. So we're in the process of improving that. I'm really interested to hear about the work of bridge clinics in ER post-overdose space, but as a whole, Red Lake has not adopted that bridge MAT service that's being suggested as a promising practice in the literature, but we're looking at ways to do that currently.
Great, thank you, Cindy. I appreciate that. We have two follow-up questions that I think we'll go ahead and jump to right now as they're directly related. Joel in Billington asked, how do we become a train-the-trainer for naloxone? Maybe
the train-the-trainer for the naloxone. I'm sorry, I was reading another question. I apologize. So the naloxone train-the-trainer curriculum, we developed that for the Bureau of Indian Affairs. It's a PowerPoint presentation, and it's available online at the IHS ODM website that I put in the web links. So all of those resources are available to be downloaded. If you are near Red Lake, we can definitely send, well, I shouldn't commit to this, but I think we can. I would feel comfortable in committing a pharmacist to come to your site to do a training with you. I know Samantha has done that, as well as other IHS pharmacists across the nation. So please reach out to me if you need direct train-the-trainer support. We can cover that curriculum with your law enforcement providers.
Okay, great. And that takes us to the next question. Dr. Ronald Shaw asked, does Red Lake carry Suboxone? And again, my apologies if I'm not pronouncing that correctly, or its generic equivalent on the formulary or as a non-formulary option?
Right, so the Red Lake tribe opened its medication-assisted recovery program in November of 2017, and at that time, the pharmacy did start carrying buprenorphine as well as Suboxone for use in support of that program. We do not have a data-waived provider on the Red Lake staff at this time that's actively prescribing buprenorphine.
Okay, thank you. Let's step back up. Pamela Goki asked, is there a TAP program for the urban community? Or she's asking to clarify, is there a program similar to TAP for the native urban community? Cipriano, would you like to address that?
Yes, thank you. For our urban programs, there is some language in regards to the MOA and the Tribal Law and Order Act around urban centers. I could send some links in regards to it. I do know that there has been coalition and collaboration agencies that have formulated a strategic plan to support multiple tribes. One that is highlighted quite a bit is the Northwest Indian Area Health Board's effort, and they've developed a strategic plan that is really focused on social marketing, raising awareness, and promoting effective communication across 44 tribes in their region. So there is a lot of information there. We could send some targeted information specifically, but we have not seen, or we haven't had too many lessons in regards to an urban center really looking at an action plan. But we do know that a lot of urban centers develop strategic plans that guide the development of their efforts as well. So I'm sure the lessons learned from Indian country could be helpful as well. And if you get my email, I could be more direct and try to send some targeted information. Thank you.
Thank you, Cipriano. We also had a question here from LaShonda, and if I'm interpreting it correctly, and I may not be, they're wondering about the process for becoming a GONA facilitator. So again, another training of facilitators.
Thank you. Well, one, in the development of the GONA curriculum, this was actually thought about quite a bit. And there is in the curriculum an actual job description and identification of things that would make effective GONA facilitators. The second is experience, attending GONA events, going to GONA events. There is personal things that could be helpful, facilitation skills, recovery, walking your walk, things of that nature that you will see on the job description itself. When we provide training of facilitators, we really promote identification for the tribes to find the right people for those training efforts. And so there's a list of qualifications within the GONA curriculum, and there is a job description with a set of skills that is identified for effective GONA facilitators. Now, that's not saying that that's what we have to stick to. We have seen tribes who identified GONA facilitator training participants who were in, I won't say early recovery, but, you know, finding balance in their life and looking at new opportunities to support their wellness. And these vulnerable members who are building the skills became very effective GONA facilitators. And so, you know, it really raises and identifies who are those community champions, who are the people that are willing to step up and lead the discussion. Now, there's a difference between a facilitator and a teacher. And so those are the things that facilitators learn overall in the long run. that we're not up there teaching. A lot of times we're just reminding the community of the strengths that they have within themselves. And so to become a GONA facilitator would be experience, identifying your own healing path, looking at the job description and identifying the skill sets identified. And then, you know, if you feel that you meet those efforts and you have some good experience and ideas about what the GONA framework is, attending a training of facilitators. We offer a 4-day training of facilitators, and we walk through the curriculum, we role play, we discuss, and we share everything that we do in the coordination of GONA events with our facilitator training participants. Our hope is that anybody attending the training will be leading an effort within a year. And so we have these consistently throughout the year. I do know that there's other organizations that provide training for GONA facilitators, but we are just one cog in the wheel supporting this wellness effort in Indian country. Hope that helps, and again, I could share more information, but that's generally our process that we use in identifying training participants for upcoming events.
Thank you, Cipriano. So we have several other questions. Let's move on to some of them. Candace Peterson asked, and I think some people responded in the chat box, and we appreciate that. Does anyone have information on where to get pamphlets to hand out to community members on opioid misuse prevention for use in tribal communities? And she's specifically looking at maybe tribally developed resources. And I'll leave that to all of you. If any of you have any suggestions, I appreciate it. No one? I think she did receive some answers in the chat box. And just so you know, because we've had such a rich discussion in the chat box, we will actually get that transcription and send that out to you and afterwards so that you have that available for your review. And moving on to the next question from Jeff Kushner. There is rarely mention of treatment. Where is the coordination with the Tribal Law and Policy Institute, the DOJ contractor, and the Native American ATTC? I apologize on rereading that. I know Jeff did make a comment about that, but if you want to further elaborate, Jeff.
Sure. Yeah, this particular webinar kind of focused on the TAP and the crisis response, and I think that as you kind of heard Red Lake's presentation, in terms ultimately is the connection to treatment, and our next webinar will specifically kind of drill down on medication-assisted treatment, both in terms of from the Tribal Healing Court and then as well as an integrated behavioral health clinic that sort of looks at, you know, the treatment as well as the pain management. And then in terms of sort of the coordination, let me also say that the Native American ATTC, Addiction Technology Transfer Center, will be on that webinar as well to talk about some of their resources. I think a lot of the coordination, I think sort of just tagging on what Cipriano had mentioned, kind of goes off and on the back in the back end behind the scenes. So when a request for TA might come to either like SAMSA, either it's my office or one of their technical assistance centers, you know, knowing what how to kind of coordinate that is often sort of done without the individual sort of knowing it, the requester, I should say, to try to align, you know, are there existing efforts so we're not duplicative, and at the same time, how can we be collaborative in making sure that we get the right resource through the right means to the requester. So there is ongoing conversations. I know that's something that we're really committed to doing, and I think depending upon the grant and other sort of mechanisms for how we can get the TA, oftentimes we just find the resource that we could deploy to be able to meet it. So it's not something I think that is always sort of public-facing in that sense. Hope that answers your question.
Right, and Kateri Koihi said, I want to address this right now while we're on it. Will the next webinar just focus on medication-assisted treatment?
Yeah, I think it's going to focus on both, I think, medication-assisted treatment, but I think specifically it's going to talk it in a larger realm. I don't think it's not a standalone treatment. I mean, there's other, obviously, the supports, I think, that Cindy had mentioned, but also I think it's going to talk a little bit about, from the justice perspective, in terms of the drug court and how they really, you know, advocate and sort of employ medication-assisted treatment from their perspective. They've been a key partner advancing that within the community. So that's what the next webinar is going to be the focus on.
Okay, thank you. And then Tim Jaworski asked, what organization had the law enforcement training? And I think, Cipriano, that might have been something that you reviewed during your portion of the presentation.
Oh, yes. Well, thank you. The law enforcement training, that was, if you Google the two web pages that I showed, was the Department of Justice, TLOA. If you Google that web page, you will get the main Department of Justice web page for Tribal Law and Order Act. And if you scroll down the left side of that web page, you will see training and technical assistance, and they break it into 3 categories. The second website that I showed that around law enforcement, and again, 80% of COPS law enforcement funding is really realmed around the field of prevention. It's a tremendous prevention arena, and in the Bureau of Justice Assistance under the Office of Justice Programs is the second web page that I show training and technical assistance, really geared towards law enforcement and public safety. Now, if you are a law enforcement agency and you are looking for training and technical assistance, again, there is a lot of TA centers that you don't have to be connected to them as a grantee, that you would still get benefit for training and technical assistance. So I hope that those 2 web pages are helpful. And if they're not, please reach out. And we know that there's a ton of stuff in SAMSA, but we're learning stuff every day from the Interagency Substance Abuse Committee, IASA, who is overseeing TLOA efforts. And if you have any specific questions around TLOA TAP trainings, you could send it to us, and we'll move them forward up to SAMSA and try to support that outreach and identification of training resources. Thank you.
Thank you, Cipriano. We are running short of time. We've got a few more questions. We'll try and get through these. Dr. Ronald Shaw asks, are there any tribes using civil commitment to mandate treatment for opiate overdose survivors? And also, what are the interventions brought to bear for the patient who is saved out in the field or in the ED by naloxone to obtain referral to or the initiation of treatment? For example, civil commitment, 72-hour EOD, initiation of medical assisted treatment in the ED. And I know Cindy has had to, Captain Gunderson has had to leave us. Samantha is still on the line, I believe, and also Chris, if either of you would like to address those.
This is Chris. I can speak a little bit to it. As far as using civil commitments, I'm not aware of any tribes using civil commitments at this point as far as opioid overdoses go, unless there is suspicion that it was a suicidal attempt. With regards to what's going on out at Red Lake and Cindy's program, I do know that when they do administer naloxone, typically that will trigger a ride to the ED, and within the ED there is a connection made to chemical health out at Red Lake. So there is an attempt at least to make a connection to connecting the patient to treatment. With regards to the emergency detentions or civil commitments, I'm not aware of anybody doing those in the field right now with respect to overdose victims that aren't identified as suicidal episodes.
Let me just add on to that. I know that one of the key partners in terms of engagement to folks following naloxone is the use of peers, individuals with lived experience in recovery. We're seeing some very promising outcomes in terms of co-deploying with first responders, immediately following up after naloxone administration and outreach, engagement in the ER, where peers have really been helpful in terms of connecting, helping through motivational interviewing, navigating people to treatment, and providing that critical linkage. I think that that's certainly an opportunity, and I would encourage folks, that's something we could talk about, I'm sure, when we talk about the MAT and next webinar, we'll talk more in terms of the role and the support that peers can provide.
Great, thank you, Jeff. And we are coming to the end of our time right now. I do want to remind you that we have the second presentation coming up on April 11th. The registration link is not available at this time, but look for it coming soon. If you are subscribe to our emails, which I included the information to do that at our website, and on the front page you can join our listserv, and please look for that registration information. Additionally, we are hoping to possibly have a fourth session that would be simply a town hall where we discuss all of this information. Questions will be available to be offered, and have some of our team here answer those. So we thank you again for participating and joining us, and we look forward to seeing you next time. Thank you very much.